Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
To the next presenter is no stranger to dental webinar series. He is our very own Dr. Furat George, and Dr. Furat George, welcome once again.
Thank you very much, Dr. Uvoh. Thank you for the invitation again. I also want to thank Dr. Casabra for a very nice lecture. It was very useful information. The reason for picking this topic for this lecture was because Dr. Uvoh mentioned that some of the audience are faculty in dental schools abroad that might be interested either in starting or implementing a dental implant curriculum in their schools, or seeing if there are ways that they can improve their current curriculum. So I thought I would share what we teach at the University of Michigan. That way it will give an idea. Maybe they are even doing better than us. They'll share some of their experience, or maybe they'll learn something that we're doing that might be useful. Okay, so can everybody see my screen?
Yes, I believe so. If you can, you can type.
I can, okay. So again, I'm going to talk about the pre-doctoral implant program, basically the dental implant education for our DDS program, for our dental students. This doesn't include any advanced program, whether it's a residency program in any specialty or any additional residency program after dental school. So this is basically what we teach our dental students. So just an introduction. As you all know, I teach at the University of Michigan. I've taught there since 2007. I did my residency there in 2004 to 2007, stayed there as a full-time faculty. University of Michigan was established in 1817. 3 years ago, we celebrated 200 years of the University of Michigan. The dental school was established in 1817. There's a typo here. 1875. We have about 125 full-time faculty members at the dental school, about 300 part-time faculty members. We have 100 students of dental hygiene in a Bachelor of Science dental hygiene program. We have about 440 dental students divided in 4 classes, because our DDS program is 4 years. So we have about 440 dental students. We have about 110 Masters of Science students in different residency programs, in different specialties, different programs, from prosthodontics, periodontics, restorative dentistry, endodontics, orthodontics, and pediatric dentistry. And we have 20 PhD students also. So it's a big school. There's a lot going on at the school. The school has been rated by the QS World University Ranking to be the top dental school in the US for 6 consecutive years. And then currently it's 3rd in the world. So and the ranking comes from so many things that they look at, how the graduates of the program, how employers look at hiring them, the data, the research that comes out of the school, so many factors that determine that ranking. Okay. Now, the pre-doctoral implant program was established in 2002. So before 2002, there was nothing formal to teach dental implants to dental students. In 2002, faculty from the prosthodontics department and the periodontics department got together and decided that they would start making a formal course and formal program to teach dental students dental implants and to provide dental implant care for the dental student patients. Because until then, every implant treatment was referred to the graduate clinic to residency programs. Okay, so the program shared by prosthodontics and periodontics. So the directorship is shared by both departments, the leadership is shared by both departments, and most of the education is also shared by those two departments. The program starts with an introduction course to implants, which happens in the beginning of the third year of dental school. In spring, summer, so in May of every year, the new class starts, and that's when that course starts, which is the first class in dental implants for dental students. So they get about 2 years of dental education and dental implants from hands-on and clinical experience and multiple courses. The course has to be successfully completed. That first initial introduction course has to be completed so that students can start seeing patients in the clinics to provide dental implant care. Our students start clinic care before third year of dental school. So in their second year, they start seeing patients and treating patients, but they cannot provide any dental implant care, even if the patient had a missing tooth that required an implant. They have to transfer the patient to another student that has completed the course, so they're in the middle of their third year or after, to treat the patient. Okay. The introduction course that we give in third year, it's course number 708. It's dental implants treatment planning. It happens in the spring, summer term. So our dental school goes through the entire year. There is no summer break, and it starts with a spring summer term for the beginning of the school year, and that's when we start our implant course. We have 109 dental students, the third year dental students every year, as well as 20 internationally trained dentists that are enrolled in the program. So our dental school has a program that is called Internationally Trained Dental Program that takes or accepts 20 internationally trained dentists so that they can get enrolled in a 2.5-year program that will grant them a DDS from the University of Michigan at the completion of the program. So there's an initial intense course, and then eventually they continue the program almost like the rest of the dental students to finish their third and fourth year of dental school. We teach them in this course the principles and basics of dental implant treatment, planning and restorative treatment only. So they learn how to plan a case, they learn how to restore a case, but they do not do any surgical procedures in implant treatment. The surgical procedures are usually done by our residency programs in periodontics and oral surgery. As I mentioned, that the course directorship is shared by periodontics and prosthodontics. So I'm the co-director from the prosthodontics side, and then my colleague, Dr. Kegler, is the periodontist who is a co-director from that side. We have some recommended reading material for students, and one of them is an article we published. Is just a technique for fabricating a surgical guide to be used for implant placement, because this is one of the basic things that we teach our students on how to fabricate surgical guides so that the placement of the implant is planned and directed by the restoring dentist so that it's restoratively driven and not, surgically driven. So in the course, as I mentioned, there is introduction to fundamentals of dental implants, We talk about clinical protocols for implant crowns, as well as mandibular implant retained overdentures, both from surgical and restorative aspects. So we teach them the surgical and the restorative aspects, basics of these, especially the surgical, so they know what it takes to place an implant. However, they don't do any hands-on training or procedures on patients when it comes to the surgical part. We also introduced digital workflow for implant surgical planning, as well as restorative design. My previous lecture that I did in this series of webinars was about custom abutment design, and that's one of the things that I teach the students. The course involves lectures as well as laboratory sessions. There are multiple lab sessions that they do hands-on treatment. Unfortunately, this was the first year that we did not get to do hands-on lab sessions because of COVID-19 restrictions. So we provided that material for them online with demos and recorded procedures. So the lab sessions, one concentrates on planning, restorative planning for an implant, and then fabricating a radiographic guide to verify that plan, and then fabricating a surgical guide to give to the surgeon so they can place the implant the way the restorative dentist planned it. The second one is an introduction to all the implant parts, instrumentations, in order to facilitate taking an implant level impression for a single implant restoration. The third part is doing a similar type of training, but for an implant retained mandibular overdenture retained over 2 implants. The other is to train them on fabricating a provisional crown, a temporary crown, on a single implant, even though this is not something they do on a regular basis, but it is important that we teach them how a provisional crown is fabricated on an implant. And then we also do a training on digital workflow from digital implant planning. So basically planning an implant using a cone beam CT scan and a scan of the patient so that we can do a virtual surgery on a patient that will be used to fabricate or 3D print a surgical guide that will be used during surgery. Something that's a little bit more advanced, something that will give us more of a visual experience, because then they see the jaw in 3D and the positioning of the implant rather than just using a 2-dimensional radiograph. The course has to be, they need to get a grade of 70% or higher to pass the course. And most of the professional schools at the University of Michigan courses require 70% grade to pass the course. They have weekly quizzes for material that they get from lectures, from material that they get from the labs, and then there is a final exam too at the end of the course. The completion of the lab projects are required also. So if a student misses a lab session, they have to make up for it and get a signature for completing that project, because that's their only hands-on training to start providing the same type of service to the patients when they get to clinics. The final exam usually is a multiple choice and true and false questions. And as I said, students need to complete this course before providing any dental implant care for their patients. What we teach in the course is we give them a history on dental implants, where it started. As Dr. Casabra mentioned, that the implants were started by P.I. Brannemark, where he noticed that titanium is integrating into bone, and most of you know the story how it started. We talk about rationale and advantages of dental implants compared to other treatment modalities. We define what osseointegration is. We go about a brief explanation of other types of implants. There are the endosseous implants, the subperiosteal implants, the transosteal implants, and so on. And we show them just to give them an idea how this history of dental implants, how implants have developed. And we reached what is more commonly used nowadays, which is the root form endosseous implant, screw type endosseous implant. We talked briefly about implant macrostructure and microstructure, peri-implant tissue, comparing tooth to implant, and Dr. Sabra did a very nice job explaining briefly some of the differences and similarities, and the implant treatment sequence, which is really important. That's something that we emphasize on so that they do not miss anything during that implant planning, because it's really critical to know how to sequence the treatment to give us a higher success rate in our treatment. We talk about some contraindications and risk factors. And again, Dr. Casabra mentioned a lot of these things. But in terms of contraindications and risk factors, some of the things that might apply to the dental students more than anybody else in practice. Because a dental student is someone who is not experienced in doing a lot of dentistry. So we don't want to give them something that's advanced. We don't want to give them something that's that has higher risks. We don't want to give them something that will be difficult for them to manage. So someone who has excessive bone loss, it won't be a case to be given to dental students. Unstable occlusion, because their dental curriculum doesn't provide them with enough education to treat complex cases that a prosthodontic resident or a prosthodontist would be working on. So cases like this, we usually don't treat in the pre-doctoral clinics. Unstable periodontal conditions, obviously, we all know that if someone has uncontrolled periodontal disease, it's not recommended to do any implant treatment unless we have the periodontal disease under control and patient is stable. Then we evaluate to see if we can move on with implant treatment. Patients who have unreasonable expectations because they're just difficult to manage by a dental student, these might be referred to the graduate clinic or sometimes to a faculty member to treat, as we have faculty practice at the school. Risk factors, these are things that it doesn't mean that we don't provide dental implant treatment. However, we have to clarify to the patient what the risk factors are. And uncontrolled diabetes, smoking, poor oral hygiene, and immunodeficiency. And a lot of the things here that we see more commonly would be smoking and poor oral hygiene, that we try to work with the patient to improve on these, quit smoking, improve oral hygiene before we even start the treatment. And then obviously consulting with the patient's physician about getting their diabetes under control before we start dental implant treatment. We explain to them from a surgical standpoint what's the difference between a submerged and non-submerged implant placement or implant protocol. Obviously, if we're placing an implant and covering it with a soft tissue and putting just a cover screw on it, that would be a submerged. So we're staging it, we're doing an implant surgery, and then going to a stage 2 to uncover the implant to make it ready for a restoration. If we're doing a non-submerged where the implant is placed, we place a healing abutment, and then the soft tissue is closed around the healing abutment, so we wouldn't need a second stage surgery to uncover the implant. More of the cases, or most of the cases in the pre-doctoral program, because they are straightforward, simple cases, they fall under the single stage approach to where a healing abutment is placed at the time of implant placement. The implant system that we use for our pre-doctoral implant patients are implants made by Zimmer Biomet. It's the old Zimmer tapered screw vent implant before even there was a merger between Zimmer and Biomet. And we used to, initially the program when it was developed in 2002, they were using the Straumann Standard Plus tissue level implant, but due to some limitations with some of the cases we were having restoratively, not surgically, we wanted to have some more of a bone level implant. And Zimmer TSV system being a very common system, as you know, the restorative platform, so the platform, the implant having that internal hex, and then the screws for the abutment have the 0.050 hex driver, is a very common instrumentation for implants. A lot of implants actually copied this design. So for something to be common for students to graduate and to be able to handle most of the implant systems out there, maybe with knowing the basics of this one, that was one of the reasons this was picked. I don't know if you all know, and I'm not advertising anything here for this implant system. I don't get paid for this, but when the abutment is seated inside the implant, there's a 1 degree taper in the abutment hex that provides what they call cold welding. There is a very solid connection made by friction between the abutment surface and the implant surface, which creates a nice solid connection between the two. The implant system that we use, again, has different diameters for their implants and different lengths. We have decided that we will only use implants that are 10 millimeters to 13 millimeters in length only. So based on the old literature that stated that implants shorter than 10 millimeters have a higher failure rate, the decision when the program had started in 2002 was that they would only place implants that are 10 millimeters or longer. So any case that doesn't have enough bone height to place a 10 millimeter implant would not be treated by the pre-doctoral students because of higher risks of failure. And it's more difficult to manage those cases in the pre-doctoral clinics. So the decision was made, and we still do the same thing. And that system has different diameters for the restorative platform. And obviously we picked the right one that would fit the clinical scenario. So if we're restoring a molar, we try to pick something that has a wider diameter. If we're in the premolar area, we pick something that would be more appropriate for the premolar area. Okay. Now, the case selection, so the pre-doctoral students are not allowed to treat any implant case that walks in. So complex cases, some cases, they can't treat everything. They only can treat patients that have a single missing tooth or two adjacent missing teeth in the posterior region. So premolars and molars only. And so they can't do anything more than two consecutive edentulous spaces in every quadrant. So in this case, we have a missing first molar on each maxillary quadrant, and they were restored by the pre-doctoral students. So that's one. So in this case, where we have two adjacent implants, that could also be planned and restored by a pre-doctoral student. The other treatment option that they can provide for their patients with implants would be a mandibular implant retained over denture, retained with two implants using some sort of a retentive mechanism. And what we use is locator abutments. So something like this would be provided. They can't do anything on the maxilla. So if the patient wanted a maxillary overdenture also retained by implants, that case would be considered too advanced, will be referred to the graduate clinic. We teach them that implant treatment should be considered as a standard of care. So every patient that walks into the clinic will, if there is an option for them to have implants, whether it falls within the pre-doctoral implant program case selection or beyond that, the student needs to be giving that option to the patient. They need to teach their patients about this option. Patients need to have stable occlusion, perio status, caries must be all restored before starting implant treatment. So we can't start treatment when there is still disease going on in the mouth. So disease control has to be completed prior to any implant planning process, which becomes an issue sometimes when patients come in and they want to start with implants, but there's a lot going on. But it's our goal to teach our students that it is very important to have a healthy mouth. Otherwise, in the middle of treatment, if you lose other teeth, it might change the treatment sequence or treatment plan for the entire mouth. Before starting any implant planning, if there's a tooth that's hopeless, we have those extracted first, allowed to heal for 2 to 3 months before we start the evaluation process. Sometimes it might look like there is enough bone to heal and do an implant, a simple implant for the pre-doctoral students. But during extraction, the extraction might be difficult. We might lose a lot of bone. So the case might become a lot more complex for the pre-doctoral students. And that's why we wait until the extraction is completed and there's some healing to evaluate if the site would be simple enough for pre-doctoral students. Our extractions usually for implants are preferably done by periodontics or oral surgery residents, so that if there is need for bone grafting, socket grafting, ridge preservation procedure to be done at the time of extraction, the residents can do that and allow for healing after that before the evaluation. The implant planning and restoration is done by our DDS students, by our dental students in the pre-doctoral clinics. So patients seen by the dental student, they plan everything. They decide if this would be a proper implant case. They do the planning, take x-rays, make a surgical guide, and then the implant surgery itself is done by either our periodontics residents or oral surgery residents. And the way it's been divided is that the patient has a registration number when they become patients at the school. The patients with even numbers go to periodontics, patients with odd numbers go to oral surgery. That way, you know, everyone is getting fair share of this type of treatment. The supervising faculty in the clinics are the prosthodontic faculty supervise any restorative evaluation. So initially when we see a patient, we evaluate if the patient has sufficient space, the occlusion is stable, there are no additional issues with occlusion and spacing and restorative needs. And then the student also does the planning and the fabrication of the surgical guide under the supervision of the prosthodontic faculty. And finally, they restore the case under the supervision of the prosthodontic faculty. And then periodontics and oral surgery faculty do the surgical evaluation. So from a surgical standpoint, they evaluate if the patient would fall under the pre-doctoral implant criteria. They have sufficient bone, they can get implants. And then the surgical procedures are done by their residents under their supervision. The cases that do not qualify as a pre-doctoral implant patient and need to be referred to the graduate clinics are patients who have more than 2 consecutive missing teeth that would require either 3 implants or 2 implants and a 3-unit bridge. Something like that would be considered beyond the dental students. Any anterior implants that would be a little bit more challenging due to aesthetic demands, those would be also sent to the graduate clinic. Currently, most of our cases are treated by using a stock abutment, a prefabricated abutment. So sometimes aesthetic outcomes are not ideal with a stock abutment rather than using a custom abutment would probably satisfy these cases. So that's why those cases are referred to the graduate clinic. Patients with unstable occlusion or a complex, restoratively complex case that would be better treated by a prosthodontic resident because it's a more complex case, almost as a case that would come to a general dentist that's too advanced that needs to be referred to a prosthodontist. Cases that require advanced surgery that would delay the treatment. So the goal is that a dental student starts a case, plans a case, and then gets to restore a case. so that they see the course of treatment from start to finish before they graduate. If a patient needs a lateral window sinus lift or a block graft that require about 6 months of healing, sometimes more, before implants are placed, those additional 6 months of healing might lengthen the time of treatment that the patient would be ready for restoration after the student has graduated. So they wouldn't see the result of their work, of their planning, and they wouldn't get to restore all of that hard work that they put in. So those cases are referred to the graduate clinic. Our grad residents are in residency programs for 3 years, so they get to see the cases from start to finish. Cases that do not have bone height that is more than 8 millimeters in the posterior maxilla or 12 millimeters in the posterior mandible. Why? As we mentioned, we prefer to place 10 millimeters or longer of implants in the pre-doctoral patients. And we can do an osteotome, a vertical approach, sinus lift simultaneously with the implant placement. And that would require that we have about 8 millimeters or so of bone. So those procedures could be done. And this would not lengthen the healing time. And then in the mandible, we like to have about 12 millimeters so that we have a 2 millimeter safety zone between the implant and the inferior alveolar nerve, since our implant cases are in the posterior mandible. Any patient that wants an immediate implant placement or loading, so a patient that wants immediate provisional placed on their implant or implant placed at the time of extraction, these have higher risks or more demands restoratively that dental students cannot address. And then if we said we would do guided surgery, flapless implant placement, also those cases are more of graduate level. So what we teach our students is how to plan the placement of the implant, how to estimate the angulation based on radiographs, and then how to fabricate what we call a radiographic guide with a metal pin in it so that they can verify with a two-dimensional radiograph if this is appropriately placed and so that it doesn't damage any of the adjacent vital structures, whether teeth, sinus, or nerves. And then from that verified angulation and position, we teach them to fabricate a surgical guide that uses sleeves for every drill size. The surgeon would be using those sleeves to help them position and angulate the implant in the plant position. For the mandibular overdenture cases, we do a similar thing, and they make the radiographic guide verified with x-rays, and then they make a surgical guide after that. As I mentioned, we use stock abutments for most of the cases in the single implant type of crown restorations. And in the overdenture cases, we utilize the locator abutments, the zest locators, for the retention of our overdenture cases. In some of the cases that the implant placement was not ideal or for any other reason that would require a custom abutment, we have that ability to design our own custom abutments and fabricate them, but we can't do them for every case. That's why we've limited them for whatever is necessary. So at the end of their last year of dental school, they are encouraged to, obviously during the third year and fourth year, they're encouraged to document their implant cases from start to finish. And in the last term of their fourth year, they're encouraged to submit that documentation as a case report so they can compete for implant awards that are given to the students. And they document it as a case report, so they, from treatment planning to surgical phase to even medical history as a full case report that will show us all the process of planning that they did, if they assisted in surgery, some surgical photographs, and then photographs all of the final restoration too. So they submit those cases, and both Dr. Kegler and I, the two co-directors, would sit down and grade the submissions and then choose the top 3 for 3 different awards. provided by 3 implant organizations: the Academy of Osseointegration, American Academy of Implant Dentistry, and the International Congress of Oral Implantologists. And those awards give them a 1-year membership to the organization, 1-year subscription to the journal of that organization, and then admission to the next annual meeting that that organization has. 2 of the organizations even give a prize, a cash prize for the students. And this is given to them at graduation. So in our graduation booklet, it mentions that this student received this award from this organization. So it's a big honor for them. We don't get too many submissions, as many students. It varies. We might get 10 submissions, we might get 15 submissions. So judging them to choose the top 3 sometimes is difficult, because a lot of them are really nice cases that they submit. Now, in the last few years, we have introduced digital technology to show them what could be done with digital technology in the planning as well as the restorative side of implants. So we have our implant planning software where we get cone beam CT scans done. We do intraoral scans or scans of the model of the patient, and we do our 3D planning for implant positioning, and then we fabricate the surgical guide by 3D printing it, and the surgical guide then is given to the residents that would be placing the implants. That way, the student gets the chance to 3-dimensionally see how we're planning the implant, how we're avoiding nerves, how we're restoratively planning the implant positioning based on a virtual wax-up, so that it's a restoratively planned implant placement. And then, as I did in my previous lecture, showing them the principles of a restoration design, especially here, a custom abutment, to show them the benefit of a custom abutment to resolve some of the cases that a stock abutment won't be able to restore. Yeah. And that's basically it for our implant program. As I said, the hands-on course, it's a big part of this that students really like, and we get the support from the implant company that gives us or lends us the implant kits for training, and that we have to return to them. But the students enjoy that hands-on experience. Some of them don't get to treat an implant case by the time they graduate. So we get about 130 to 150 implants for the pre-doctoral implant cases. We have 129 students, but not all of them get to do implant cases. Some of them do 2, 3 implant cases, others don't do any. And again, some of it is also the lack of number of patients that would accept a treatment, due to cost or any other reasons, medical conditions and so on. Okay. So this is a nice explanation of our implant program for our DDS students. Are there any questions that I might be able to answer?
All right. Thank you so much, Dr. George, for that that is the template that we want to reproduce in Africa. I mean, sincerely, that is my dream. Hopefully someday we'll be able to bring that to pass. So we want to start the lab exercise. I'm just going to, with permission, just copy what you've already done. That is what dental students are doing at University of Michigan. And other schools have something, pretty similar. And I want to adopt that. I want to call on, so we do have there's someone from Kenya, there's someone from Ethiopia, there's someone from Nigeria right there. I'm going to call on someone from Somalia, Dahir, Mohammed Dahir. Can you hear me? I want you to just share your experience. We're going to go and do, we're just going to run through some a post-test question, but I just want to get a little feedback from dental students in Somalia. Mohammed Dahir, can you hear me? I'm going to see how to, I just need to. Yes, Dahi, you are able to talk, Mohammed. Mohammed, I've turned your mic on, so if you want to say something, I just want to share your experience. And there's Shelimo Benkar, you are from Kenya. If you are able to speak, just tell me about you. What kind of experience do students have in your country? Shalimo? Shalimo, can you hear me? Okay, Shalimo, your mic is on. If you want to, do you guys have dental implant courses? Okay, I'm going to move on to Ethiopia. If you are Beth from Ethiopia. Bethlehem from Ethiopia. You can hear me. Your microphone is on. If you want to say, share your experience, I'm going to call on you to do it. Dr. Solomon Ofiemo, you are from Nigeria.
Yes, I am from Nigeria.
Okay, go ahead, Solomon. Do students have a dental implant course, like pre-doctoral students?
Yes, we have some undergraduate lectures on implants theoretically, but not the practical aspects. But undergraduate lectures on slides, yes, we have some lectures on that.
How long are the lectures that you have? What is the length?
About 3 lectures, 2 hours per lecture, and about 3 different lecture days.
So that is all. So you know, dental students in Nigeria spend 6 years in dental school.
Yes, about that.
And they have just 6 hours of lectures on implant currently.
About that, yes.
I mean, so this is the reason why I say, you know, Dr. George, how long is this implant course?
The implant course is through the spring-summer term. So we have about 5 or 6 lectures, and then we have 4 to 5 lab sessions. However, that is the introduction course, and there are multiple other courses on dental implants throughout the 3rd and 4th year of dental program, and those give more, you know, advanced and more information. But the introduction course is what teaches them the principles of what they can provide as treatment in the pre-doctoral clinics.
Okay, thank you so much. Is there somebody from Ethiopia you could just to share your experience? I've called on El Shade from Ethiopia. Can you hear me? Anyway, if at some point you want to speak, just go ahead. Beth, you can say something if you want. Do students have an opportunity of learning implants currently? And so I believe, just from the little survey I've done, I just wanted to hear from you directly. I know that they have very, very few lectures, and that is the reason why we have decided to go ahead with this. Hopefully we can turn this into a course, an online course, so that you can get the didactics, then we'll move on to some lab sessions. I want to go ahead and run the poll just based on the question on Dr. George's presentation. So let's go ahead, and I'm going to launch the poll. We have 5 minutes. And if you have any other question, please type it in the chat, and Dr. George is going to answer. So we have 5 minutes just based. So this is not a, you know, just from what you grasp from what he said. Go ahead. We have 5 minutes to answer the questions. All right, we have 1 more minute. Please answer as much as you can. We have 53%. I'm sure we can get to 70%. All right, I'm going to end the poll, and Dr. George, please, could you just go through the questions?
Yes. So it's funny because I sent those questions and then I made changes to my presentation. I eliminated some slides, but I'm glad that Dr. Casabra covered a couple of these questions. So, okay, so the most commonly used dental implant nowadays is the root form screw type endosseous implant, as we all know. In the blade implant, there's a company that's trying to bring it back. It's not that common. And then subperiosteal implant. Also, there's a company trying to do some 3D printing for those, but again, it's not that common. According to the U of M, University of Michigan Pre-Doctoral Implant Program, the cases that could should be referred to the graduate clinic. So the students are able to do a lower overdenture retained by 2 implants. So this is actually not the incorrect answer, but the last option, 2 implants replacing number 5 and 6, or number 1, 4 and number 1, 3, depending on which numbering system you use. Basically, a canine is considered an anterior tooth. The dental students cannot restore that case. Periodontal fibers are perpendicular to the tooth surface, while peri-implant fibers are parallel to the implant surface. That was covered by Dr. Casabra. And yes, the answer is true. Which of the following is not a risk factor for dental implants? And hypertension is not. And then osseointegration is a clinical term meaning lack of implant mobility. And that's not true, actually. This is false. Osseointegration is a histologic term, which means a direct contact between the implant surface and the bone. And this was a tricky question because I had that in my slides and I took that out. So I expected to see some. And then prosthodontic faculty are the main supervising faculty for restorative and surgical procedures for implant. That's false because we provide only restorative supervision, while the periodontics and oral surgery faculty would be providing the surgical supervision. So that would be false. Again, something that doesn't affect on your clinical practice. It's something that I mentioned in one of the slides. That's all.
All right. Thank you so much. Thank you so much for those just review, just to sometimes you just want to find out if people are grasping the concept. Just something that was mentioned. I'm going to call Dr. Wang. Please, do you have any information as to dental students in Asia, in terms of when do they start an implant course, and what are they able to do?
Well, thanks again for having me. I just want to say we are really fortunate to have Dr. Fred George to be our implant program director. I think it is important to appreciate the periodontal and peri-implant health, and Dr. George is really phenomenal in making sure the implant has the longevity and high success rate. I think that's something I really want to echo to Dr. George for the wonderful presentation. And coming back to your question about the implant education in Asia, I think it's similar to Africa, a 6-year program, and usually it's at the last 2 years. The last year is a full-time clinical internship. So they usually have lecture preclinical exercise on the 5th year, which is 1 year throughout. And of course, on the clinical component, most of the school, as far as I know, they have limited experience in restoring implants. So they actually don't have much opportunity to expose to clinical implantology. So mostly are taught at the continuing education. But of course, now gradually a lot of more discussion on how to involve dental student in the treatment planning process, as what Dr. George was mentioning about digital planning. And I think it is critical to have as much exposure in the planning part. So, you know, complication can be avoided a lot by having a quality treatment planning. Because one thing that's important to know is that most of the clinical complications occurred after 6 or 7 years. So within the first 5 years, everything seems to be fine, but then, you know, the problem would evolve after 6 or 7 years. So, you know, the dental student also have to understand this perspective together with the educating the public about, you know, potential complication and intrinsic risk associated with dental implant. I think another major concern is the public still not aware about some intrinsic, you know, risk that's associated with the implant therapy.
All right, thank you so much. I mean, as you were just speaking, it occurs to me.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator